Dr. Claudia Fegan was appointed Chief Medical Officer of Cook County Health in 2013. In this role, she provides executive oversight for the health system's medical practices and helps inform health policy initiatives. Dr. Fegan joined Cook County Health with 15 years of practice as an internal medicine physician. She began her career at Cook County Health as the medical director of an ambulatory care center and progressed through the health system, serving as the medical director of Fantas Health Center and the chief medical officer of Southside and Southern Suburban ACHN facilities. Dr. Fegan was awarded the Soul of Medicine Award by Physicians for Social Responsibility for her work inspiring medical students to commit to careers in social justice, and is the 2017 recipient of the Paul Cornely Award for her work as a healthcare activist. She has testified before Congress and is known as an expert in healthcare reform in the US and Canada. She is also certified in healthcare quality and management and is a diplomat of the American Board of Quality Assurance and Utilization Review Physicians. Dr. Fegan is also the president of the Health and Medicine Policy Research Group and the national coordinator of Physicians for a National Health Program. Dr. Fegan attended Fisk University in Nashville as an undergraduate and received her medical degree from the University of Illinois at Chicago. Everybody, please give a very warm welcome to Dr. Fegan.
Thank you. Thank you very much. And it's really exciting for me to meet all of these young physicians or soon to be physicians. Um, so you've heard a lot about me, but I'll tell you a little bit that's not in the, I guess, on the websites. I was raised on the south side of Chicago. Um, Both my parents were immigrants, so I'm first generation from this country. Uh, my mother fled Nazi Germany in World War II, and my dad came from Jamaica. And they met where would immigrants meet in New York um, a long time ago. And my dad was a labor union organizer, and my mother was a social worker. So I come by my activism normally. I was raised in a household where we were taught to never be silent when we saw something that was wrong, to speak out, speak up, and to act. And so I brought that to medicine, which was unusual at the time that I started medical school because when I went to medical school, most of the committees doing interviews and selecting candidates were looking for people who were politically inert. And I think that we have a generation of physicians who are predominantly politically inert, and yet we have such an opportunity within our communities to make a powerful impact on policy. When you speak to an elected member of Congress and you have those initials after your name, it makes a big difference. And being a physician, I say it is a privilege. It is a joy as well, because people allow you into their lives. They tell you the most intimate details about themselves, and then look to you for advice and counsel. And you learn a lot about society by taking care of patients. And so it's been my pleasure to do that for over 40 years. But I think that the important role of a physician is as an advocate. And as I tell young physicians all the time and trainees, is that your voice is never more powerful as when you are advocating for your patients. And so I think that that's an important role in society for physicians to play, and that it's one that we should not squander, that we should spend time educating ourselves about the issues that affect our patients, and then take that opportunity to speak up and speak out about the things that we as a society fail to address that results in some of the problems that our patients confront on a daily basis. I think that COVID was a classic example when we decided, rightfully so, that bus drivers and um, uh, grocery store workers were essential workers, but we did little to protect them from the virus that was really rampant in our communities. And so I really enjoy working at Cook County. Cook County has been around for over 185 years, and um, we live by the motto, the quote from Louis Pasteur that is on the statue in front of the old county building, which says, "One does not ask one who suffers what country they're from or what is their religion. That you suffer is enough for me." So we have always taken pride in being able to provide people care, regardless of their origin and regardless of their ability to pay. One of the biggest fights we had um, was a battle between the medical staff and the county board when they decided that we should charge people a co-payment for their medications when we had always provided medications free of charge. But things have changed. We lost that battle, although we do still provide those medications without co-payment if the patient is willing to provide us documentation that they're not able to pay for it. Um, when I started at county in 2000, let's see, 80% of the outpatients we saw were unfunded, and 50 to 60%, over 50%, like 56% of the inpatients we took care of were unfunded. And so many more of the inpatients were unfunded because if you had a problem or you were sick enough to get admitted to the hospital, we were able to get you coverage with the requirements of Medicaid in the state of Illinois. Today, about 65% of the patients after the Affordable Care Act, about 65% of the patients we have take care are funded. And so people ask, well, who is left unfunded? The assumption is that they're all undocumented, and we do take care of a lot of people who are undocumented. We don't require documentation for you to be seen as a patient within our system. Um, and we recognize that asking people about funding, whether they have insurance or have Social Security, is a deterrent for people to be seen. So we try not to make that as a barrier. And I just try to point this out to folks because they say, well, we'll take care of everyone. There's a federal law. There's EMTALA, which is the um, emergency medical and active labor treatment act, which requires that everyone, and EMTALA now expand, it's not only required in the emergency department, but also applies to outpatient facilities, says that anyone who presents themselves before a physician or a medical facility care provider should have a medical screening exam to determine if they are in need of emergent medical care before you determine how that care is going to be paid for. But if you walk into any emergency department or any clinic, the first thing you see is the registration desk, where people know they're going to be asked, how will this visit be paid for? So we think it's very important to make sure that patients are able to present themselves, state their problem without fear of having to provide documentation of their citizenship or without having to provide proof that they have a means to pay for the care that they are in need of. And then they're more likely to receive that care and they're more likely to stay and get what would be appropriate care for them. So we've been doing it, like I said, for over 185 years. I think we're getting close to 190 years now that we've been doing that. But it's become, it becomes more and more of a challenge. The EMTALA was passed in the 80s after members of the staff from Cook County testified about the dumping that was occurring to us. And it still occurs. Let's be clear about that on a daily basis. There is hardly a day goes by that we don't have patients who come from been seen in another emergency department or an outpatient facility and directed because they didn't have funding, they should go to the county. I will get calls from places that say, we have a patient here, they have a diagnosis of cancer, but they're not insured and we want to send them to you. Um, and we accept those patients because we think that everybody deserves health care. But it's an acknowledgement that our society does not provide for the care of everyone, even though we spend enough money to do so. Numerous studies have shown that we spend enough money on healthcare in the United States today to provide care for everyone who lives within our borders. And when I say everyone who lives within our borders, I didn't say every citizen, I didn't say everyone who was documented. We spend enough, we spend more than any other country in the world per capita on healthcare, and yet we leave a third of the people who live in this country either uninsured or underinsured. And what do I mean by underinsured? I mean that people may have insurance, um, but because of co-payments or deductibles, they're not able to get everything that they need. Because you have to remember that medical illness or medical debt is still the number one reason for bankruptcy in the United States. I also think that, I mean, the work that I'm proud of is the work I've done with Physicians for a National Health Program. And you folks have been working from Vermont, where you have Bernie Sanders, and I know Senator Sanders. I've traveled to Canada with him to explain to him when we visited hospitals in Toronto, what the difference was between the way care was delivered in Toronto and the way we're able to deliver it in the United States. And also explain to them why you have to wash your hands when you go into the room as well as when you come out of the room. Nehemiah.
Yeah, I just if this was a good time to ask a
Sure.
question. I just was wondering how you initially got involved with PNHP, how you heard about the organization and started being active.
Yeah. So before I went in to work for Cook County, I was in private practice with a doctor by the name of Quentin Young. And Quentin was active in the civil rights movement. When Martin Luther King was staying in Chicago for the summer, um, Quentin was the doctor who took care of him. My parents were very active in the civil rights movement, and they knew Quentin. And actually, it was not Quentin, but one of the other partners in the practice who invited me to join the practice. I met Quentin as an intern when I was training at a hospital in Chicago called Michael Reese. It's no more. But Quentin was working at county during the day and seeing patients from his private office at night, and he would come at night to make rounds. And he would hold court. He would sit in the nursing station and tell stories, and um, so there was a natural connection there. And so when I finished my training, not immediately, I joined another group first, but Quentin and his partners asked me to if I would come and join their practice. And it was through that I joined that practice. I hate to say that for all the folks, yeah, in 1988, and attended my first PNHP meeting in the spring of '89. So it was a natural progression. Um, and we took care of Jesse Jackson was often a person in that practice. Carol Mosley Braun, who was the first Black woman senator in the United States, was a patient in that practice. Judge Turkle, who written a lot of books about um, the about people in general in the U.S., as well as Mike Royko, who was a famous columnist. There were lots of folks in that practice. Um, the matter of fact, our waiting room was really quite a place to hang out and uh, learn a lot about history and what was going on in the movement.
That's awesome. Thank you.
Thank you. So, I want to say that I've enjoyed the practice of medicine. I seeing patients is the most fun thing I do all week, and still, even as the CMO of the third largest health system in the country, I still see patients. As on the outpatient now, I've stopped doing my inpatient wards, although I really love doing the wards, but it's a lot to make sure you're doing a good job with that and trying to do. As a matter of fact, the first time I remember I was on service, and I was on service for 4 weeks, and the COO, after I finished 4 weeks of service, said, what were you doing all of that time? I said, I was taking care of inpatients. He said, please don't ever do that again. Um, we we did cut it down to 2 weeks at a time so that I wasn't away from all of the other things that have to be done. But I also raised two wonderful children. I was married to my husband till he passed away. We were married for 37 years, so I felt like I had it all. My son is a sports writer. He covers the lowly White Sox, the worst team in baseball today, and my daughter is a visual artist um, who makes a lot of protest art. And I think that both of them could easily, without prompting, give a single payer talk off the top of their heads. They heard it so much during their being raised. I brought my both of them, well, really my daughter more, to PNHP annual conferences. Macaulay.
Yeah, I wanted to kind of go back to something that you said earlier. You mentioned like early in your career that experience that admission committees and interviewers were really looking negatively at people who spoke about political
Mhm.
like political reasons for going into medicine and things like that.
Right.
And certainly as a as a trans person going into medicine, that's something I worried about a lot when I was applying to school, because it's kind of impossible for me to answer the question why medicine without talking about being trans. It was
Right,
a lot
right.
of me sitting and looking at interviewers if I didn't talk about it. So I just wanted to know how you kind of dealt with that, and what do you think needs to happen for that to not be a negative? I mean, it's better now, but to be even less of a
It is better, but we need more people on those willing to do that extra work, like sitting on admissions committees. You know, it's extra work. And, you know, it's a thing. I remember one of the doctors describing this to me when I was asking them about being involved in PNHP. You know, when you're in medicine, and especially if you're in medicine trying to have, and people talk about this now, we didn't talk about it so much then, about work-life balance. And then you're asking them to come out to meetings or to participate. It's like, I finally got, you know, a piece of the pie, and then you want to cut it up into smaller pieces, right? Um, so, and I'll tell you example, I was an undergrad at Fisk, and I specifically had gone to Fisk. My parents knew the dean of Meharry Medical School. Um, and my parents knew the dean of Meharry Medical School because when he was in Chicago getting a pharmacology degree with his wife, they didn't have any money either. My parents didn't have any money, and they found each other on one of those. Well, we don't do that anymore. There were literally bulletin boards where people put up a piece of paper and said looking to share an apartment. So the four of them shared an apartment together to pay rent. And he said, you know, if and I was smart. I was, you know, high school valedictorian, and you know, they had high hopes that I go to medical school. And so Ralph, because Ralph said, you know, when I as a dean, I don't look for um, uh, African American students in the Big Ten schools, and you know, I look for them at small liberal arts schools. So I went to Fisk, and taking a long time to get a story. I went to Fisk, and Angela Davis came to town, and some of you may not know who Angela Davis is, but you know, she was a radical. She was a communist, and she was coming and she was speaking in Nashville, and I went to hear her speak. And I was sitting in class the next day. I was in my biochemistry class, and a young lady came and handed a note to my professor, who was a professor from Meharry, who was teaching the class at Fisk. And you know, he took the note. He said, and he told me that the dean of Meharry wanted to see me after class. And everybody was like, "Ooh, Dean of Meharry." Well, they didn't know that I knew the dean, you know. But Ralph had called me over to his office, and the reason he called me his office is he said, I heard that you were at an Angela Davis rally last night. Well, first of all, I didn't know that Nashville was that small, you know, that he would know that. Um, but then he said, I thought you came here because you wanted to go to medical school. And that was like an aha moment. Why did me attending an Angela Davis rally have anything to do with wanting to go to medical school? But here was the dean telling me that he thought that that was a problem. Now, Meharry was the first school that accepted me, but I didn't go to Meharry. I went to University of Illinois because and you know, I loved him. I mean, you know, he was a friend of the family, but I had to be able to use my voice. And I think that the important thing about being a physician, as I said, being a physician advocate. Now, you have to be mindful. You know, there is a hierarchy in medicine, and you know, there are certain things, the way in which you conduct yourself. But I don't think that silencing your voice is a good way to go. And I think the way that we get better is by having more diversity in the people we accept in medical school, and having more diversity in people who make decisions. You know, when I first became uh, I started as the medical director of Stroger Hospital, which is our flagship hospital, replaced the old Cook County Hospital. I went to my first clinical chairs meeting, and I looked the room, you know, and here I am, a short, and I am short Black woman, and I walked into a room with almost all white men. There was one white woman. I said, "Oh, this is going to change." Because if those are the people who make decisions, you know, we really have to, we benefit, and it's nothing wrong with you know, there was nothing wrong with any of those men, right? But we all benefit from interacting with folks who have different backgrounds from us. And we will never have enough, you know, every Black person in the United States will not have a Black doctor. They don't even all want one. But by training with Blacks, and by training with Latinos, and by training with trans, with LGBTQ plus, or training with a variety of people, we are all better for that, and we will deliver the message better, and we will be we will develop empathy. And that's what medicine is really built on, is empathy. And if you can't understand someone's background, whether they're an immigrant or they are a, you know, Native American, you will never be able to provide them with the best care that they deserve. Sam, can I answer your question?
Yes, I wanted to ask more about sort of your administrative role, because I'm curious, because we rotate through the Harris County hospital system. So
Mhm.
I'm interested in sort of like what you think some of the major challenges facing like public county hospitals are right now.
Those are two different things, the challenges, because it's always funding, right? It's always funding. But, you know, one of the most important things I do is to provide oversight for the quality of care that we deliver. So we have a weekly meeting called CERT, Serious Event Review Team. And we have an electronic system where anyone who works in any capacity in the hospital can enter a note, electronic note about an event, if they think that that event poses a safety issue or a concern that should be reviewed. And so in the course of a week, we'll get, you know, 100 to 120 or 30 of those, and then of those events listed. And it might be that a patient didn't get their medication on time. It could be that a patient had a poor outcome that people think could have been prevented. It could be that someone was left waiting in radiology for longer than they should have been. It could be anything, right? It could be that the bathroom wasn't cleaned. But then our quality people and our risk managers comb through those 100 or so, 150 events. And then every Thursday, we spend an hour and a half reviewing the top 25 and decide what is the appropriate way to address them. Is this something that it's a problem with nursing and nursing needs to look at it? Is it a cross departmentals? In other words, were there multiple failures? We talk about the holes in the Swiss cheese aligning in just a way so that something bad happens, or it just almost happens, because near misses are just as important. And then, you know, if it crosses multiple departments, could it be medicine, anesthesia, and nursing, or could it, you know, surgery and anesthesia and medicine, you know? So if that's the case, then we need to do a root cause analysis, which is a multidiscipline evaluation of the event. How do we prevent it from happening? And so what we're talking about is, you know, people. physicians used to feel that they should be able to they spend a lot of time reading and learning, and they are trained. They should make decisions about what is the best for a patient. But what we know is that over time, there are best practices that are identified. There are articles, peer-reviewed articles that are published that say, this is the way you take care of blood pressure, or these are the best medications you use for this, or this is and so we have to endorse processes. Physicians are poor processes. They like to just kind of think about it, be fairly autonomous about it. But actually, we know that are things that are shown that, for example, patients who are discharged from the hospital should be seen in follow-up in less than 2 weeks. It's even better if it's, less than 10 days from the time they're discharged. They're more likely to ensure that they are taking the medications that will make them better. They're more likely to have, to reinforce the things that we learned while they were in the hospital to treat whatever their condition is. And so I say that no one goes to work to do a bad job, but people make mistakes. And so what are the duplications we can put in place to make sure that a patient gets the right medicine, that a physician makes the right decision? So why do we have something called timeout when we're getting ready to do a procedure? So everyone in the room says, stop, let's make sure this is the right patient, this is the right procedure, everybody's agreed, this is the procedure we're going to do. And so how do we prevent patients encountering the bad things that can happen in medicine? So that's my biggest job, is to ensure the quality. And then when someone doesn't do well, someone makes a mistake, was it one person who made a mistake, or we didn't have the right process in place? And if it was one person who made a mistake, it was a physician who did this, who should have done that, why did that physician make a mistake? Did they just not know? Or is this a pattern that they're having difficulty? Is this a time when we need to put a collegial arm around that person? Are they going through something, a bad divorce? Have they developed a substance problem? Is it, or is it that they really didn't know and we need to help them get additional training in a particular area? So it's recognizing that we spend a lot of time and money to train physicians. And so that if they make a mistake, we should just toss them out with yesterday's garbage. That we should try to figure out what it is they need to be successful. Now, sometimes, for example, when you have an anesthesiologist who's developed a substance problem, maybe we can't let them be anesthesiologists, because that's like not a good thing to put someone around a lot of habit-forming drugs every day if that's what their problem is. But it's, doing those sort of things. So that's my big job. But the biggest challenges that public hospitals are facing today is that we are still training physicians. We are still basing the model of healthcare centered around hospitals. And actually, that's not where we're going to deliver the bulk of care going forward. That more and more things can be done as an outpatient. For crying out loud, people can go home the same day after they have a hip replacement. And if truth be told, hospitals are not good places for people to hang out. There are lots of infections, lots of bad things happen in hospitals, mistakes happen in hospitals, and that we are really going more and more to outpatient model. However, for that model to work and be successful, people have to have the resources. It takes a village, right? People, if you have someone who's an immigrant who doesn't have a lot of resources, they don't have family because their rest of their family may not be in this country. Do they have the resources to take care of themselves at home? And if they don't, can we provide those resources? Or is there a way that we can provide them a temporary place while they are trying to recover? So it's looking at those sort of things, looking at the model of how do we train our young clinicians, and how do we take care of patients, and what are we building for the future? And every community wants to have a hospital because, by the way, that's an economic engine for the community. It provides jobs. But sometimes hospitals should close because what they're doing is so low volume, it's not safe. And it's acknowledging that when you take care of patients, there's a certain amount of muscle memory that occurs from doing the same thing over and over again. And if you have a delivery room that's only delivering you know, 2 or 3 babies a day. Maybe you shouldn't be delivering babies because you may not have the, people may make mistakes when they're challenged with someone who's a little different or more complicated. Yeah, Hamza.
So we recently had a talk by Dr. Susan Rogers, who is one of the past presidents for PNHP, and
Good
she
friend
mentioned
too.
something that I was that you just mentioned, where it's like sort of just like the newer people, and we need to focus care more around patients rather than the hospital. One of the things she mentioned was that like the culture of physicians is just like rather than asking those questions, rather than caring about status, we just sort of take care of them. Can you talk a little bit about how you sort of create that culture? Is it just the way you recruit new people, or is it just when you bring in people, you just create that environment for them?
Well, it's exposing people to those conversations. So, for example, CERT, we used to do that in person before COVID, and I would invite residents and fellows to attend that meeting so they could see the process of asking those questions and looking. But now we have it as a Teams meeting, and CERT, which used to be maybe 2 dozen people in a room, is now a meeting with like 70 to 80 people. And the nurses, the nurses gave me this because they said my meeting, the CERT meeting, was the most fun meeting they went to all week. Because what would happen is they would have, for example, a nurse didn't change a dressing in time, or a nurse didn't give an antibiotic. And they would say, the nursing administration would say, well, we've disciplined that nurse. And I was like, whoa, 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 not so fast. So first tell me, how many patients was that nurse taking care of? Who had gone to lunch? Was that nurse on the floor by herself, or was there only 2 of them with 30 patients? And so what was the staffing like at the time? Because like I said, nobody goes to work to do a bad job. And if she forgot, what other things were coming at her at that time? So it's exposing people to those conversations. So the nurses quickly learned that saying, well, this was an agency person and they're no longer with us, was not an acceptable answer to me. It's really understanding why. If you've hired the correct people and something goes wrong because somebody didn't do something they were supposed to do, I never assume it's because that person is failed. Is did we give that person the resources or the support that they need to do their job? And too often, that's what we want to do. We want to blame the individual. And what I've learned is a failure of the system, that we have not put the resources there. And so what's a big challenge in medicine, even though we practice as individuals, is recognize everybody does their job within context. And what was the support or context for that person? Nehemiah.
Yeah, I think even like your answer to that question kind of showed like the value of having a clinician, someone who has been in the healthcare professional role, the value of having someone like that in a administrative role now, being able to oversee and make decisions and whatnot. So kind of with that in mind, my question is, as we're kind of all figuring out, the direction we want to take our careers, whether it's like clinical work, research based, administrative based, and a couple of them with co-interns are not even in medical school. But I wonder what are kind of things that you would say are good to think about when considering like a job in, as a chief medical officer or a
Right.
medical director, uh, um,
Yeah,
do
I
you
didn't go to
that
medical school to
role?
become a
Like,
CMO. I went to medical school because I wanted to take care of patients. And, I call this my megalomaniac moment. I started off working in a fairly qualified health center on 43rd Street on the south side of Chicago. And I was taking care of patients and with problems. And I tell this to residents all the time, you will never ever take care of a patient. You will teach a patient how to take care of themselves, because you give information to the patient that they have to apply, for it to be beneficial, because they're only going to have, 15 or 30 minutes with you, or if they're in the hospital, maybe you're 10 minutes, right? And you go visit them every day, but they have to be able to manage their condition. And what I realized, if I teach a patient how to take care of themselves, that's great for that interaction between me and that patient. But I thought, wow, if I could make sure that that happened in every exam room, then I could make a bigger impact. And then I thought, wow, if I could make sure that happened in every exam room with a clinic. What if I did multiple clinics, right? So you could see where this would go. One of my proudest things in my years of healthcare was when I was over Fanta's clinic, and we saw 2,000 patients a day at Fanta's. The patients often were immigrants, and the homeless shelters would drive school buses up to Fanta's and drop everybody off to be seen at Fanta's. We called it Fantasy Clinic, right? But I wanted to do something about diabetic foot ulcers. And so I made a rule, and I put up a sign in every exam room that all diabetics must have their shoes and socks removed before the doctor comes into the room. And that one act meant that, when the doctor came in the room, they were immediately drawn to look at their feet. So I didn't say to the doctors, you must examine the feet of every patient. I said all diabetics must have their shoes and socks removed before the doctor enters the room. And I went home and told my husband, I am doing it now. I have made a difference, because how many diabetic feet we identify. Um, and it's all about processes. But, you'll find your space. I mean, I got involved in administration because I have a big mouth, and I became president of the medical staff. And the hospital recognized that I was a force to be reckoned with and decided to invest in me. So when I finished my tenure, termed out as president of medical staff, they hired me to be the medical director of the hospital. But not before. They sent me to Kellogg to take business classes. They sent me to Joint Commission. I got boarded in quality and learned what the rules were. And so those investments paid off, because even when that hospital failed, when I was hired at Cook County, I was the first doc to work at Cook County who was boarded in quality. But I immediately showed why this was something that we needed to do. And I encouraged everyone to learn about quality and process improvement, because that's how we get better in medicine, is by understanding the processes. Patients, docs think they just take care of patients, but what's the process? What are we doing when we're treating heart failure, when we're treating diabetes, when we are even, procedureless? What is the process for identifying the procedure that's needed?
Thank you.
Yeah. So obviously I get get excited about the work I do, because I love making a difference. And as long as I believe that I make a difference. Susan Rogers is a good friend of mine, and we've known each other for years. We don't live that far from each other's. And actually, her husband and my brothers and I used to ride our bikes together when we were kids. So it's a small world, actually. But I convinced her to join PNHP, and I said, because we need more physicians of color in PNHP, and then told her after she had joined, well, okay, now I need you to be president. So it's worked out well. Any other questions? I hope you guys have enjoyed your your time, because I think you're the next generation of activists. We need folks who we can teach about these things and who can speak to it as they go back. And you will be an asset to your classmates because of the things that you've learned. And physicians, there's so many things that we don't learn in the curriculum of medical school per se, that are so important in terms of shaping the kind of physicians or clinicians we'll be. Trying to see who's trying to reach me. Okay. Well, I mean, I could tell you, although we're near the end of our time, so I won't start with another story, but I certainly, you could reach out to me. I am here at Cook County and we're always looking to hire. I'm always hiring. So, and we have we do have the largest single site internal medicine residency in the United States today, but we have wonderful programs in family medicine. Our OB program, our residents come mainly from Northwestern University, and our surgeons come from a joint program between Cook County and Rush, which is right across the street. So think about coming to county to train, because we train lots of doctors. I say we train doctors, we cast them out into the world. I travel a lot, and I have never gone anywhere where I have not encountered docs who haven't at some point in their career passed through Cook County, and that includes China and Samoa and Fiji and Tanzania and South Africa. Everywhere I go, I run into somebody who says, "Oh, I was at county at some point." So our docs make a difference wherever they go.